from Baghdad, Iraq, showing a case of PCI for RCA chronic total occlusion, which was successful only on the second attempt. The case is a 70-year-old female who is hypertensive, not diabetic, and non-smoker. She had PCI for the RCA at 2008 with a 2-cipher stent implanted. She also has paroxysmal IF with a history of multiple minor strokes that resulted in mild cognitive impairment without paralysis. She had carotid artery disease, angina on exertion was her presentation, and the echocardiography was normal. This is the apicaudal view showing heavily calcified vessel with a critical stenosis at the proximal RCA. The epicranial view shows a critical stenosis at the proximal and mid-LID, and there is retrograde filling to the RCA. This is the RCA view. It shows total occlusion of the mid stent. So it's a total ISR of the mid-old stent. So the case is a high syntax score and is a clear-cut case for surgery. But the surgeon turned back the patient because they were afraid of that the patient is a high risk for stroke. The plan was to start with PCI for the RCA, starting with antegrade wiring and maybe dissection and re-entry. And if that failed, then the patient is going to be returned back to the surgeon. If the surgery was refused again, then at that time we can attempt retrograde PCI, but of course after dealing with the LID that was calcified. This is a bilateral injection. It shows a long occlusion segment with calcification and a blunt stump. So it's a high JCTO score. So we went on with femoral approach using a 7 French guiding catheter and plus 1. Summary of the first attempt is the lesion was crossed by a wire but couldn't be followed by a microcatheter, and the 1.5 millimeter balloon couldn't cross the mid part of the stent despite using guide catheter extension, and this balloon was the smallest balloon available at that time. Also, we used a 1.5 and 2 millimeter balloon at the area, and that was inflated up to more than burst pressure in what is called the granuloplasty in a way to modify the stump, and was not successful. So what to do different in the second attempt? We prepared a small balloon that was 0.8 millimeter. Using a long femoral sheath up to ascending aorta is useful in giving a better support. A sheath that is more than 50 centimeter up to the ascending aorta. And maybe attempting a different wire trajectory. The other thing is using excimer laser atherectomy. This is useful in balloon uncrossable lesion. It works on the same wire, i.e. it's a monorail catheter, but this was not available. And finally, rotational atherectomy can be used in such cases, but this needs an exchange of the wire into a rota wire, and that requires us to cross the lesion by a microcatheter, which was not possible. Going back to the case, a Corsair Pro XS microcatheter was used. We tried to keep the wire in the vessel architecture, and this was guided by stent edges using orthogonal views. The proximal and the mid part of the lesion crossed by Gaia second wire, but the distal cap couldn't be crossed. So we use a pilot 200 wire. To our surprise, at this time we were able to cross by 1.5 millimeter balloon. We think that we had better alignment of the AL guiding catheter after using a long femoral sheath, and also we think that the wire trajectory was different. Multiple balloon inflations was done using 2.0, 2.5 and then 3.0 balloon. It's important at this stage to avoid contrast injection because excessive manipulation may cause dissection and strong contrast injection may increase this dissection. IVAS showed the wire being intraluminal. The distal edge of the stent was well expanded, but there is a significant new intimal hyperplasia, all part of the stent, and the mid part, where there is mostly an overlap of stent, there is stent under expansion. And proximal to the stent, there is here 180 degree of calcification. And this is the proximal RCA. And here we can see the hematoma and dissection at the proximal RCA as was expected. A stent 2.7 by 24 was deployed distally just before the bifurcation, then dilated by NC balloon to the burst pressure, first 3 mm and then 3.5, but there was still some waste at a localized part. So we decided to go with a shockwave balloon C2, 3.5, 8 cycles with partial success. IVAS showed better expansion of the old stent, but not to the degree that we wanted. The IVAS also showed the proximal part. Let's see. It also showed that the proximal RCA hematoma and dissection was increasing at this time with compression of the lumen. So we debated a lot about putting a further stent, but finally we decided to put a 3.5 by 38 millimeter stent, followed by NC balloon inflation. We can see a good inflation at the mid part. Then a 4.0 by 24 stent was deployed at the proximal part, post-dilated by a 4 millimeter NC balloon, and this is the final result. So the message from this case is that CTO intervention requires availability of equipment and expertise. Whenever a second attempt is tried, new approaches and the plans should be kept in mind. And thank you.